Good morning, everybody. Welcome to the July meeting of the CQC board. We have an apology from Kirsty Shaw, who has to be elsewhere today. We have, I think, no declarations of interest. Can I just check nobody has anything they need to add? That takes us to the minutes of the public board meeting on the 23rd of June. Are they a true and accurate record of everything we discussed then? Thank you. I'll take that as approval. There is nothing outstanding on our action log. Is there anything arising anybody wants to raise that's not otherwise on the agenda? Good. Right, Ian, that moves straight into your report, please.
Thanks, Peter, and good morning, everybody. Relatively short update from me this morning, and then I'll hand on to colleagues. We've first had meetings with a number of new faces in the health and social care world, and we have written our letter of welcome to the new Secretary of State. Peter and I are looking forward to meeting the Secretary of State in person when we're able to, which we're hoping will be reasonably soon. There's also been new faces at NHS Digital and the NHS Confederation, and again I've met the new chief execs of both of those organisations and had positive meetings, and I think it's just I've certainly felt that post-COVID, a number of our relationships have deepened and strengthened with our partners because of the work we've done together, and I'm hoping we can capitalise on that in the months and years ahead. Moving on to the all-party parliamentary group on learning disabilities, Debbie Ivanova and I attended the meeting recently that was held by the group to reflect on 10 years since Winterbourne View. It was a group that included parliamentarians along with people that have used services and relatives of those who've used services, some of whom were at Winterbourne View. It was a relatively short session, but an important one, I think, and I think it was an opportunity for us to talk to the group about the work that's being led by Debbie and the work we as an organisation have done for people who are in acute services, who are being looked after with people with learning disabilities and autistic people. I think there was a good discussion by those in the meeting around the important point about needing to have greater focus on community services for people with learning disabilities and autistic people, and the fact that progress needs to be accelerated because as we are doing our work, what we're finding is poor practice that's translating into hospitals being closed, and that translates into a need to find alternative support for some very vulnerable people. Ideally, we'd like to see that in the community, and we've been very vocal on that in the past. So again, it was an opportunity just to reflect on the last few years, what we've done and what other partners are doing, and the progress that's been made. I want to move on and talk about Peter. Peter sadly is coming to the end of his 6-year term, and that means that the opportunity to take over as chair of CQC is open. The advert is live on the public appointments website and will be live until the 2nd of August. So we're very optimistic of a large and diverse field of people putting themselves forward to fill what I think we'd all agree are very big shoes. I'm sure we'll all pay tribute to Peter at the appropriate time, but certainly it's a sad time in many respects for us. So I haven't gone yet, Ian. No, you haven't gone yet. I won't embarrass you further, and I will move on. So I talking about our developing our monitoring approach. I've spoken a few times over the last few months on the way in which we are moving out of COVID and what we're doing in terms of our approach to regulation in this time period that's still in COVID, but things are in some respects improving. I've said again repeatedly that in March 2020 we suspended our routine inspection program and moved to a risk-based approach, and that's still our core position. We're not doing any routine inspections. We are inspecting based on our perception of risk. It does mean, though, that we've evolved our approach, so that it means that during COVID, we've been trying to strike this really important balance between discharging our duty to the public to give them assurance around the care services that they're using, whilst at the same time recognizing the enormous pressure that the providers we regulate and the people that work in those providers were under, and indeed continue to be under. And I think we've said again and again that what we have seen as we've spoken to providers and as we've been out and done inspections is truly remarkable efforts that have saved many lives over the last year or so. That said, of course, concerns continue to be raised with us, either from the public or from people that work in services, and of course we have to respond appropriately to those concerns. And in some cases, that's a conversation with the provider. In some cases, that's a face-to-face visit, and in other cases, it may be a full inspection, which may ultimately lead to the re-rating of a service. We've launched the next phase of our work, where we are we are improving the way we're approaching the analysis of risk, but also we're now being much more open with the public about doing that. So we've introduced statements on every provider's website now that says if we are satisfied and content that provider doesn't need an immediate inspection, and that we're again reinforcing the point that if somebody reading that information disagrees with our assessment of a provider, then we are flagging to them that they can talk to us through our give feedback on care service, and that's on a number of providers' websites. Of course, we still reserve the right to go out and inspect, and we will continue to do that. We're upgrading this material on a very frequent basis, no less than monthly, and it'll be clear on the website exactly when the last time we looked at the information in relation to that provider was. Based on the information that we get from the public and from the people that work within services, we may do a video conference follow-up with the provider. We may, of course, cross the threshold and do a visit, or we may do a full inspection, and we obviously reserve the right to do any one of those things. But of course, as ever, we're trying to strike this balance around doing the best job we can for the public, whilst at the same time recognizing the position that providers are in. And I expect we'll continue to be evolving our approach during the latter half of this calendar year, as we build our new regulatory platform and our new regulatory approach. We'll be piloting things with small groups of providers, and then deciding if we're going to go ahead with them, and of course communicating that to providers. And we're doing that through routine bulletins, as well as things like roundtable events, conferences, and so forth. So I just thought I'd just flag to board members that again, we've taken another step in terms of evolving our approach, but we are an awfully long way from routine inspections, and I just wanted to highlight that to everybody. That's it from me, Peter, and I'll hand over to Kate if there's no questions from my section.
Thanks, Ian. Kate.
Thank you. Thanks, Ian. Good morning, everyone. So I'm going to update on two things today. Firstly, about closed cultures and our work on that agenda. And then secondly, I'm just going to say a few words around visiting in care homes. So firstly, on closed cultures work, lots of work continues to progress. We're currently consulting and engaging on our role in assessing providers' use of surveillance, and very much looking at that through a human rights lens. As board knows, we've developed a new quality of life tool, which we are looking at really using to understand what it feels like from a person's perspective who draws on care, as to what it feels like to receive that care in that setting. So we're using our quality of life tool out on our inspections in some inpatient services, but also in some adult social care inspections. And we've got groups of people helping us evaluate the effectiveness of that tool in really reflecting what it feels like to receive that care. We're looking at some case studies to keep on testing out whether our new methods for identifying places at risk of closed cultures and regulating them with our different tools to ensure that they are as effective as possible. We're working up a research proposal, as board is aware, to look at what the ingredients are that tips a kind of poor culture into an abusive culture. And finally, our colleagues at Air Intelligence are making progress around kind of prototyping a dashboard that's going to support our inspectors to understand services that may be at risk closed cultures. So lots of work going on that front. If I may, I'm just going to briefly turn to talk about visiting in care homes, a really important topic that we focused on over the last year. We really welcome the removal of the cap of visitors into care homes. We know this is something that care home residents and families have been desperate to see happen over the period of the pandemic. And we know that visiting has a kind of key contributor to people's well-being and general quality of life. So we're really clear that care homes should be making this happen wherever it's safe to do so. We want to recognise that for care homes, for registered managers, so they will also be no doubt delighted that more of their residents will see family members more regularly. Just conscious that registered managers continue to have that challenge of thinking about how they make this a reality. So thinking about visitors needing lateral flow tests around access to personal protective equipment, about making sure they've still got the right space and ability to clean down communal areas, etc. So we are continuing to ensure that care homes are following government guidance on this. We absolutely want to see visiting happen and really welcome the lifting of the cap. Just conscious as well that the pressure this will put on registered managers to make this a reality for lots of people who have lots of expectations following this announcement. We're continuing to look at visiting on all of our care home inspections. So since the beginning of March, since the 8th of March, we've done 1,763 care home inspections where we've looked at a variety of things, including infection prevention control and visiting. Over 97% of those inspections confirmed that visiting was happening. In those small number where we had questions, we then took action to get confidence that care homes were doing what they needed to do to ensure that people were able to see their loved ones. So just a brief update from me on how we continue to focus on ensuring that visiting is happening. And as I've said on many occasions before, if we have any concerns about a blanket approach to visiting not taking place, that is absolutely something we would action to look to be assured that that was not what was going on in those care homes. Thanks, Peter.
Thank you, Kate. Nobody wants to come in? Okay, good. So I think we'll move on. Ted, to you, please.
Thank you, Peter. As I've outlined in the report, the written report to the board, hospital services remain under tremendous pressure at the moment, and they face a combination of three exceptional demands. First of all, the rising tide of COVID patients during the current resurgence, which they are seeing is different spectrum of patients from previous COVID episodes, but still causing a lot of pressure. And I think there's uncertainty about how high the number of admissions will rise over the next few weeks. And that uncertainty itself is causing a lot of concern. There's also, importantly, a record level of emergency patients seeking emergency care, both in hospitals and, as I'll come to in a moment, for ambulances as well. And these are, some of them are COVID patients, but many, in fact, the majority are non-COVID patients. And we are seeing a very high level of emergency demand this summer, which is exceptional compared to previous summers, and really reflects the level of activity that most of these services see in winters. And again, there's a great deal of uncertainty of how the emergency pressure will continue through the rest of the summer and into next winter. And of course, on top of that, the third element they're facing is a backlog of planned care, which they are working very hard to tackle. But this is in the setting of managing the emergency pressures I've just mentioned to you. And these factors combining together are having a big impact on their ability to provide patient care as well as they'd like, but also have big impact on staff, many of whom have been working in a highly pressurized environment now for well over a year. And I think we need to recognise the impact this is having on services in the long term, and the fact that if you like, the normal summer quiet period for emergency services is not being seen this year. Yesterday, I had a meeting with some chief executives from ambulance trusts in the country, and they reported they are too facing record demands for care. The ambulance trusts, several of them are reporting their busiest days ever in the last week or so. And this is extraordinary for summertime. And I think this inevitably is having an impact on their ability to provide care in the way they want to. Under these circumstances, it is really important all parts of the system work together to provide care as safely as they can during these exceptional pressures. yesterday I agreed to do more work with the Ambulance Trust and bring them together with the group of emergency medicine clinicians that we've been working with for a while to try and develop guidance around how to meet this demand, particularly working on delays in ambulance handovers at emergency departments, which I think is a major concern for all parts of the system. Not only does it delay the care of patients waiting in ambulances, but it delays the care of patients who are calling ambulances, who are seeking emergency attention. And I think more can be done in that line. We know that some centres manage to maintain very low levels of delays in ambulance handovers. Others have much higher levels. And I think what we want to do is to work with those centres that have learned how to manage this well to spread best practice. And we'll build on the work from the workshop we did with emergency medicine teams last month, which I reported to the board last month, and the guidance from that has been really very well received. I think an additional point I want to make is the problems we are seeing are manifestations of long-term issues within the models of care and how it's provided. We've highlighted these previously in our state of care reports. The pandemic has exacerbated these, but it hasn't introduced them it hasn't introduced them for the first time. And to some extent, we're seeing issues that we should have resolved in previous years coming to the fore because of the pressures from the pandemic. And it's imperative that not only do we deal with the immediate pressures on the system, and we are very much supporting services to do that, we also need to deal with the underlying problems with the models of care, and the pandemic has really emphasised that. If we are going to provide care for patients in the way they need, at the time they need, the whole systems need to work together around new models of care. And if we don't do that, patients will not be able to receive the care that we want them to. And the pressure on staff to provide care under these difficult circumstances will continue. So thank you, Peter. That's what I wanted to say about current problems in the service. I'll take any questions from that or on any other issues that people want.
So Mark Saxton wanted to come in. Mark.
Thank you, Chairman, and thank you, Ted. It's always great to hear how you and your team in the Hospital Directorate are working with providers, especially in these difficult times. And always you talk about being patient care and patient focus. So, I thank you very much and your team for that. No, sorry, I had a slightly slow finger before because I want to go back to Kate and to Ian, if I could, please, about the monitoring approach and the closed culture update specifically. And my question is, if not already the case, how quickly will we be embedding the closed culture indicators into our transitional monitoring approach to monitor risk and reinforce safety?
Thank you. Shall I go first? And then I don't know whether Mark or Ian will want to. So Mark, at the moment, we are working on a dashboard that provides that information for inspectors, and already we are bringing together much more intelligence into one place for inspectors than they've ever had before, with a real focus on what are the key things that may trigger an inspector wanting to go out and just go and observe the care being delivered within a place. So we are much further ahead now than we've ever been. Our intention with our kind of transformation work that we've been talking about is that any requirements that we want to embed in our new system, in our new regulatory platform, has closed cultures woven through it. So we are pulling together data and intelligence in a much more effective way now than we ever have been, and we are going to be locking those requirements in as we continue our developments around our regulatory design work and our regulatory platform as well. Can I just check, Mark, if I described that correctly? Is there anything you want to add?
I've very little to add to that, Kate. That was perfect. I think what our the development of our new data and insight capabilities and the regulatory platform will give us is this opportunity, as Kate said, to weave in the powerful insights that we are now. We will continue to improve upon developing into the hands of inspectors at the moment that they need it. So not just closed cultures, but all sorts of other indicators of risk as well will be brought into their portfolio of insight. And the closed cultures work that we have is one of the first opportunities we have to bring that in. So yes, absolutely right.
And finally, Peter, just one quick thing from me. Mark, we're hoping to come back in September to give the board a more detailed flavour of what I was referring to around what the new method will look like, to try and bring to life some of the things that Kate was just mentioning there. Thank you.
Okay, thank you very much.
Thanks, everybody. Robert.
Thank you. Well, my question was to Ted, and it was about the reference to the system oversight framework of NHS-EI and the recovery support programme. I've read bits of that, but could you just outline in a couple of sentences how that differs from special measures?
Special measures was an intervention for an individual provider, Robert, where the provider was provided with, in NHS Trust terms at least, was provided with extra support from NHS Improvement to help them drive the improvements that we'd identified in our inspections. We still want individual providers to get support when they need it, but we've recognised in many cases there's a bigger issue around the system that supports that provider. And we've encouraged NHS Improvement to look at how it can support systems as well as providers. Now, clearly, every time that we find issues that need this external support, we're going to have to design a bespoke package that meets the needs of the problems we've found. So there's no kind of generalised approach. But this is, if you like, a more system-based view of this, and it is meant to be more clearly supportive. There was a problem that special measures was seen by many to be, if you like, punitive. It was seen to be a kind of badge of shame for trusts that when we found problems. We recognise that trusts are in difficult circumstances. I just talked about that a few minutes ago, and really we should be looking at support for trust as something that they welcome rather than something that they see as a negative. And so not only is this more system focused, it is more bespoke for individual organisations and systems, but also I hope it will be seen as more supportive and less critical of organisations.
Yeah, thank you. And I'm sure that's very welcome. Given we will unfortunately still find trusts we rate inadequate and therefore under the current regime qualify for special measures, how do we keep our line of sight on progress, bearing in mind the intervention of systems in this? And I mean, does that complicate the work we're asking our inspectors to do?
No, I don't think so, Robert. We will continue our approach in terms of recommending the recovery support package and the support that goes with that when we find inadequate care. Equally, we will continue our monitoring of that and our repeat inspection. And we've agreed with NHS-EI that organisations will not have that support taken away until we've seen the improvement we need to see going forward. So in those terms, it works like special measures. But having said that, I think it is, if you like, a more developed approach than the special measures, which sometimes was a bit of a blunt tool.
I agree. Thank you very much.
Thanks, Robert. Stephen.
Thank you, Peter, and Ted, thank you very much. I mean, a really helpful report, and as you were rightly saying, I mean, some quite worrying aspects to it. And I'm kind of interested in the sort of boundary issues and interfaces here across into Rose's world and primary. Are any of the pressures on A&E and ambulance services sort of a result of sort of behaviours, changes, things going on across the boundary in primary? If they might be, are we yet seeing any sort of interesting work by ICSs to sort of manage these interfaces? Are we seeing any good practice in how these big services sort of relate to each other and talk to each other to try to manage these pressures across the system?
Yes. I'll hand over to you in a moment, Rosie, because I know you want to come in on this. But just to say, Stephen, I think it's really important that we look at this as a system issue, not as an issue of parts of the system. And I think one of the things that we must absolutely not do is kind of blame one part of the system for other parts of the system's problems. Urgent emergency care, which is at the centre of this, is a continuum, and we need to manage it as a continuum. And as I said, the model of care as we provide at the moment really is not delivering the care that people are looking for, and we need to look seriously at the model of care. And I hope that the ICSs, as they come in, will be able to transform that model of care to provide urgent and emergency care in a very different way going forward, and that will affect all parts of the system. There's no doubt at the moment that the front door emergency department is seen as a kind of default for any urgent and emergency care, and the truth is it is not set up to provide the care that many people need, and they'd be much better cared for elsewhere. But I'm sure Rosie will say that GPs feel the same, that they are a kind of default place for people who need urgent emergency care to go. And actually, we need to reflect on this and see that we're not providing care in the way that patients need or want it to be provided, and we need to address that. We need to build care around the needs of patients, not about the needs of providers. And a lot of the debate at the moment is focused on the needs of providers, and we need to focus on the needs of patients. So the models of care have to change, and we've seen that in winter after winter after winter. This is not new to the pandemic. The pandemic has brought it to the fore, and it's brought it to the fore at the height of summer, and that's what's different about things now. But I'll hand over to Rosie, because I'm sure she'll want to comment about the GP side of it.
Thank you. And in answer to your question, Stephen, about what we're seeing at integrated care systems, I think we are seeing some interesting models of care, but they tend to be very often small scale and not rolled out fully. Sometimes also they are not accelerating and not being delivered at the pace we need to see. So lots of great examples of innovation and what people are trying, and we've tried to highlight that in our provider collaboration reviews, which we are coming on to later. And I would encourage systems to be looking at those provider collaboration reviews, to look at what other systems are doing, learning from each other, and really starting to kind of roll those out at pace. I just want to completely echo what Ted is saying. We need a new model of care right across the system. I'm very, very worried about what's happening in general practice at the moment. I visited several practices over the last month, and I've spoken to GPs from across the country, and the themes that we're seeing are repeated right across the country. The themes that we are hearing about are firstly the very, very high demand. I'm speaking to GPs who've been GPs for 35 years, and they've said they've never known demand like it is. And in July, that's, which is often slightly quieter in historic years, that is highly unusual. And they're saying that demand is driven by a variety of things. One is there is a growing amount of COVID. Secondly, people worried that they've got COVID and the symptoms related, worried about COVID vaccination side effects. Sometimes the vaccination programme, as we know, has been a huge success, but sometimes people get some side effects. That's driving lots of people to contact their practices. They're still seeing late presentations of a whole variety of illnesses that for people who didn't present during the time of the pandemic, and a growing number of people with mental health type problems and anxiety and other symptoms. So lots of demand. On top of that, I think we've got a very exhausted workforce. Morale, many GPs are reporting to me, is the worst it's ever been. They're working very, very long hours. I've spoken to GPs who said they're not sleeping because of the stress, and also the impact of isolating the workforce, isolating when they need to. They're also adding on to that the vaccination and the additional hours that they're working to make sure the vaccination programs have been the success that they have been. And I think the other theme that we're consistently hearing is because of the backlog of elective care and the backlog in other parts of the system, and the pressure on other parts of the system which work very closely with primary care, so community nurses, mental health teams, for example, and the acute trusts. That means that GPs are holding a lot more clinical risk in the community while people are waiting for procedures. And so for everyone who's on a waiting list, they're getting a lot more people coming in saying, can you write and hurry up my appointment? Can you give me extra painkillers? I need to be off work longer, those type of things, which adds to the workload as well. And that is that kind of extra clinical risk they're holding within primary care is certainly a factor. So in terms of what we're doing, we're very conscious, firstly, to make sure that we continue to develop our approach, as Ian was saying earlier, to make sure that we focus on those areas of risk. We're not doing routine inspections, as Ian has said, and absolutely just to reinforce that message. And we are very much looking at how we can support primary care, and my teams are working through a whole series of actions to see what more can we do to support a very fragile system at the moment. I'm also meeting with senior stakeholders next week from NHS England, from the RCGP and the BMA to have a further discussion. But I just wanted to flag that, as Ted has said, that the system is under huge pressure at the moment.
Can I just come back on just one aspect of what Rosie said? I think it is important to understand that the fact the model of care does not deliver the care that patients need has an impact on patients, but it also has a profound impact on staff, because the only way they can make it work is often by working extraordinarily hard to actually sustain the service. And if we are going to take some of the pressure off staff, we have to give them a model of care that works for patients. It will save them so much pressure, but also provide the care that patients need.
The slightly frustrating thing in this conversation is that we would have had much the same conversation before the pandemic. I mean, obviously the pandemic has vastly accentuated all these issues, but they were there beforehand. And what we have seen, I mean, absolutely to your point, Ted, is the response has been work harder, not to find different ways of working, to work smarter, and somehow we have to help the system to move more quickly to help itself.
I totally agree with that, Peter.
Stephen.
Peter, if I might just come in on that. I mean, there's something coming out of this discussion for me, I guess, by a question, particularly to Rosie. Does this suggest we should be sort of putting more of our own resource into trying to find those solutions? We're now sort of using the language of an approach to inspection activity that's risk-based. Might it also be kind of solutions based? If we're seeing small scale ICS activity that seems to be pointing us in the right direction, should we attempt within very constrained budgets and resources to kind of ramp up the focus we're putting on the solutions to some of these big long-standing system issues that Ted has been talking about so powerfully?
I'm not sure.
So
I want
we are very Sorry, can I?
Rosie, I was going to bring Ian in.
Can I mention something first of all, or Ian, do you want to go first, and then can I add something?
Yeah, I mean, essentially what I was going to say was I think what we bring to the table that's unique as the regulator is that perspective across primary, secondary, and social care, both in terms of seeing the outcomes for people around safety and quality, but also I think a glimpse into the commercial drivers to some of the decisions that are made, and they're particularly acute in and around general practice, and particularly acute in social care. So I think we bring that perspective to the table, but I think the power that we've got is the convening power, in the sense that, you know, if we bring a group of people together, and Ted was talking about this earlier on around the work we've done with emergency physicians, for example, the work that Ted personally and colleagues are doing around maternity, where taking a topic, worked with Royal GMC, NMC, Royal Colleges and others on a range of different potential interventions. But I think for me there is this classic sort of strategic question, which is, if you look at what's going on at the moment in and around health and social care, there's good solid plans around ICSs and the legislation's on track and all of those good things, but realistically ICSs will not be up and running for 18 months, 2 years before they're starting to make a difference. Looking sort of very, very far ahead, people talk very eloquently about things like genomics. People talk about people changing their behaviours and public health, and people owning their own health. That's sort of long way in the future. The issue, frankly, is what do we do in the next? What does the system and what do we contribute to the next 6 months? And that's the bit that feels to me at the moment which is, to Ted's point, just paddle faster rather than actually what can we do. So for me, that the real focus is what are we seeing on the ground that we can sort of recycle in a really tactical way to make a short-term difference. That feels like the space that's the here and now, and of course support ICSs and things in the long term. But that's my worry at the moment. That feels like the gap at the moment. So thanks, Peter.
Yeah, thank you, Rosie.
Just to say, we are absolutely trying to do that, Stephen, where we can. We are absolutely delivering on our purpose on looking at where we find concerns and making sure that the public, when we've identified those concerns, that they're actioned and dealt with, so that actually the quality of care improves. But we are working with all of our external stakeholders to look at actually when we're identifying themes, when we're identifying ideas that we hear from practices, we can actually flag those, we can raise them, we can see what we can do within our assessment frameworks and our regulation to be able to support the right things to happen. And we're also trying to share best practice where we can, and as I said earlier, the provider collaboration reviews is one way of doing that. We also meet regularly with local clinical commissioning groups our teams do across the country, and talk about what we're finding and raise any concerns with them. So we're trying a whole variety of ways to support in whatever way we can at the moment.
Thanks, Rosie. And Jora, you wanted to come in, Jora.
Yeah, just a quick question, and just more sort of knowledge base. At the moment, because our key lines of questions and our whole methodology is built around individual providers, as Ted said, we're moving potentially across to inspecting individual providers to more systems, integrated systems of care built around an individual. How would we then assess that sort of integrated care? What sort of are we working on a methodology already? And I just wondered how we're progressing, because 18 months doesn't seem a long way away, and I don't know if we're going to be averaging out all the providers in that, or what the algorithm's going to be. Just interested in our
yes. Oh, sorry, Jora, I thought you'd finished your question. Apologies. So just to confirm, we are working on that methodology. We are looking, building on the work that we've done with local system reviews, with the recent provider collaboration reviews. We are looking and working with the Department of Health and Social Care and NHS England on what systems regulation could look like, and how we absolutely look at that from a person's perspective using services. Hopefully we'll be able to share more detail with that as we go forward.
So I think in response both to Stephen and Jora, when we come on to the provider collaboration reviews in a short while, I think you see both sides of this. I think you see the failings that we have unearthed, and you're also some really good learnings for where things have worked well. And I think that's the benefit of being able to look at the systems. But whether it's looking at systems or individual providers, you can point people to good ideas, but it's leading horses to water and all of that. They have not always been terribly good at following up on things that haven't been invented here, and that's a challenge, I think. Rosie, was there anything else you wanted to say in your section, or are we going to move on to, I think, Chris?
Happy to move on. Thank you, Peter.
Thanks, Rosie, very much. So, Chris Usher, I think it's to you.
Yes, thanks, Peter. So just a few updates from in Kirsty's absence and from the People Directorate. So in terms of mental health and well-being, we've currently got a pulse survey open at present, which is focusing on mental health and well-being. That shuts tomorrow. It's been open for 2 weeks. That'll help provide vital feedback to ensure we're harnessing a healthy workplace. In terms of culture and change, we're working to ensure our approach on culture is embedded into our transformation programme. The first element to this is our Transforming Data and Insight TDI programme. where we're engaging with colleagues to help develop ways of working that consider cultural changes raised from culture inquiry. And alongside that, we started delivering our new learning modules to support line manager capability. This has started with a module that is currently running on embracing change. In terms of diversity and inclusion, we created a voluntary D&I coordinator role, which will work closely with our D&I manager role, which is already in the organisation, hopefully aimed at helping to provide visible leadership and promote good D&I practices. And finally, in terms of talent resource, so this month we opened an expression of interest window for this year's Shaping Our Future Leaders programme, and also level 3 and level 5 management apprenticeships. There are 90 spaces available for those across those 3 programmes, which will commence in September and October. We're also holding our first executive team talent board of the year to look at recently completed talent grids and succession plans for our executive colleagues. So that was it for me, Peter.
That's great. Thank you, Chris. Mark Chambers.
Thanks, and it's great to see the emphasis on leadership programs and apprentice programs to build our pipeline of talent. I think that's an essential thing about being an employer of choice, but it's also, you know, these are also sort of key tools in helping us build increasing diversity at a senior level within the organization. You know, what are we doing in relation to these programs to ensure that they are as inclusive as possible, and that we you know, we generate expressions of interest from you know, as widely as possible within the organisation?
I'll attempt to respond to that, Mark. Well, I think it's around publicising these and around how we promote them internally in the organisation and ensure we're connected in with the networks, which we are, to make sure that everybody is aware of the opportunities and everyone has the same opportunity to apply as everyone else.
Yeah. I don't think Jill will allow us to miss any opportunities here. Ian.
Just to build on that a little bit, I think we've got a series of specific interventions, specific training, specific opportunities, but the D&I coordinator role I think is really important, because that's a person who's a local advocate who can draw to people's attention some of the roles, because I think my reflection of some of the challenges that we've had, and not that we haven't got the right pieces in place, it's just sometimes people don't know about them or they're reluctant to apply, and so the D&I coordinators are really there as sort of little local coaches, I suppose. They have a multiplicity of roles, but are there to coach people into applying, putting themselves forward for things, people expressing interest for things that perhaps they wouldn't otherwise have done without a little bit of a gentle shove. So that I think is an important part of this. But I think it just from my point of view, it is making sure that we do lots of small things consistently well, rather than sort of 2 or 3 big things, because that everyone does the 2 or 3 big things, but it's the lots of small things done really well that I think is going to make the difference.
Good, thank you. Chris, back to you on the performance report.
Yeah, so just a fairly short update this month. We'll do a fuller one next month, which is the quarterly update. So this is May's update. So in terms of registration, at the end of May, simpler applications have taken 27.7 days to process. That's an improving trend, and we are seeing some real progress in that area. Complex applications is taking 128 days, which has been monitored closely. They're lower volumes than the simple ones. Significant work is underway to support delivery, as well as support our transformation change, which will help us transform the service for the future. In terms of safeguarding, performance for safeguarding alerts is 93%, and from concerns it's 97%, both against a target of 95%. Whistleblowing, as I mentioned last month, we introduced a new measure to capture how we mitigate risk on whistleblowing inquiries, with the aim that record our action within 5 days. For the year to date, we've recorded our initial mitigation within 5 days in 75% of cases, against a target of 95%. Our current data right up to now shows this is an improving trend. However, to understand that early findings further, a review was carried out of all the cases outside of 5 days to ensure appropriate action has been taken. That found no concerns on our action, but highlighted where additional training and communication was required as we embed this measure. Enforcement, 94% of enforcement action was served within 3 days, which we continue to monitor. And from HR perspective, turnovers again stable at just under 8%, sickness at 3.24. Finally, from me on our money, at the end of May, our revenue budget is underspent by 3.1 million. This is across pay and non-pay, and reflects a combination of ongoing reduced travel and timing of delivery of our activity. We're still working up our forecast plans where we'll see where we'll anticipate we'll end the year and report that to board next month. On the capital side, the underspend at the end of May is 1.2 million. I think this is largely down to timing. We're still on the working assumption that our budget will be fully utilised this year. That's it from me.
Thanks, Chris. And do you want to add anything on the safeguarding? Because I mean, at face value, it's concerning, but I think it's probably not quite the picture that is being painted.
Absolutely, Peter. I think what the individual chief inspectors have done is they've done a deep dive on the individual cases in their areas, because I think when we first saw this, it obviously caused concern. But it's a new measure that was introduced in April. It involves putting additional information into our CRM system. And a couple of things that we found as we did the deep dives, one of which was some of the inspectors weren't necessarily looping back round to tick the box on the CRM system. So there was an issue of recording, even though the work itself had been done. But secondly, there was also there were also issues around when they found safeguarding issues whilst out on inspection, they were just dealing with them straight away and weren't raising separate safeguarding queries, which again is exactly the right thing to do in terms of the people using the service, but from a recording point of view was causing some challenges. So there's a couple of things that we're just working through around recording, but this is relatively low numbers to the point where we have gone back to every case and checked that the right things were done in the right way. And you know, it is a topic that we have done a lot of work on in the past and continues to be seen as really important work by all of our inspectors. I don't know whether any of the chief inspectors want to talk specifically or not around their areas, but certainly it's a topic that we as an executive team have looked at very closely.
Good, thank you. Robert, you had a question.
Yes, surprisingly not about that. My question was about staff turnover, and I noted the figure for turnover of those under 2-year service, which is clearly significantly higher than the overall turnover rate. And I wonder how that benchmarks against other organisations. Is that good, bad, or concerning?
Honest answer, Robert, is I'm not sure, but we can find that out and we can bring that into the update next month.
So
unless others know.
I was only going to remind you, Robert, because you and I have been on this board a long time, that it was a major concern several years ago, where it was very high and was definitely suggesting we needed to change the recruitment process to make sure that people who thought that working from home was going to suit their lifestyle and everything else really understood the cons as well as the pros. So I was actually quite pleased that it had come down from the very high levels of a few years ago. But Ian, you were going to answer Robert's question.
Yeah, I was. I certainly was going to part answer. I think a couple of things. I think recruitment and people movement at the moment just doesn't benchmark at the moment. I think coming out of COVID, I think what we're seeing is all sorts of very odd patterns of things going on. I think what we have seen is a fair amount of movement over the last few months, because there's a perception that we're coming out of COVID. People have decided they want to move on to other jobs. Coincidentally, I was with the engagement, performance, policy and strategy leadership group yesterday, and we were talking about this for that cohort of people. And one of the things that became very obvious was that there's a lot of people going out on promotion, which is good. A lot of younger people leaving because they see that they want to take their career in a different direction. A lot of people have clearly hung on as well, waiting till COVID finishes or is perceived to finish before they make a move. There's a whole range, I think, of reasons that people have got for leaving. It is a topic that we look at very carefully, because I think, as you say, people leaving after a relatively short period of service isn't necessarily a good thing. The other thing that's worth remembering is that we've got an awful lot of people on fixed term contracts at the moment. As part of the change work, we made a decision to keep the majority of new starters onto fixed term contracts. And again, for some people, they understandably, if given a choice between staying on a fixed term contract versus going on to something permanent, they may move. So there's a range of disrupting factors in all of this. So I'm sort of slightly loath to simply give an answer to the question, but to be reassured, it is a question which we are looking at very tightly, and looking at the variability across the organisation, because I think 12% is an okay number at a headline level, but it's quite variable between teams, between regions, and so forth. So I hope that helps.
Thank you. I mean, obviously, there's a disproportionate overhead in terms of inducting and training people, because they then leave. That's the point I would make. Apart from the obvious implications for whether we're an attractive employer or not, which I hope we are.
Yeah, and I think that last point, Robert, goes back to the point I was trying to make with the work that was done a couple of years ago, or probably more than that now, to make sure that we were clearer when we hired people what was involved, and we were hiring the right people for the right reasons. Okay, good. Mark, I'm hoping that you're going to give us a nil report. Oh, sorry, Mark Saxton wanted to come in. Sorry, before I come on to Mark Saxton.
Yeah, Chairman, I just wanted to add, not only have we looked at our recruitment processes, but also our onboarding processes to support people coming into the organisation. I think I'd be more worried if the under 2-year turnover figure hadn't dropped in the same percentage as the overall recruitment figure, turnover figger. Because we have seen that slide backwards during this process for a lot of the reasons Ian has said. But it is a theme that we asked to look at a couple of years ago, and we now get this data for us to actually have ask these questions, and to see the exec answering them and doing the work that we need to onboard people and recruit people into our organisation effectively.
Thanks, Mark. So can I move on to Mark Sutton, who I hope is going to give us a nothing to report on cybersecurity.
Absolutely, Peter. Yes, it is a new report this month. No security issues to report.
Excellent. Very good. Thank you. Chris Day, over to you.
So first of all, let's just talk a bit about some parliamentary business. We've recently contributed to an inquiry into support surrounding people with an autism diagnosis, where we outlined some of the work on closed cultures from our finding from the Restraint, Seclusion and Segregation report. Today, in fact, actually just a few hours ago, the DHSE launched a 5-year strategy developed following engagement with autistic people, but also following the findings of our report, Out of Sight, Who Cares? The strategy sets out some commitments around providing £25 million worth of funding for capacity and capability, 18 million for crisis prevention, and 21 million for local authorities and community discharge grants. I think this is a real tangible example of how CQC's independent voice leads to a direct improvement in the way services are provided and offered. And also, I think the outcome of this is excellent, but just wanted to make the board aware of the impact of our report, both in the conversations we had with DHSE and the conversations with Parliament. There's also just been, as Ian said earlier, a lot of interest in our support for our role in system regulation moving forward. And the bill's second reading in particular, there was lots of support from MPs who represented the views of both providers and public groups around the idea of creating a common framework for a view of health and care regulation in one, overseen by CQC. So that's very positive. Just in terms of publications, we're publishing our equality objectives, which help bring to life some of our commitments made in the strategy. The engagement on those objectives has been significant. There've been a number of, I think about 1,000 people have been involved in some of the drafting of those objectives, both people who use services and providers. And we also had over 100 CQC staff involved in workshops around them. We've identified 5 themes: amplifying the voice of people most likely to receive poor care or have unequal access, using data to understand the response to equality risks, working with others to improve equality outcomes, use our independent voice to reduce inequalities, and making sure that we ourselves as an employer are appropriately understanding inequality in our own environment. The key thing about those objectives that they are baked into our transformation plan, with 34 of the 39 objectives directly linked to elements in the transformation programme. So I just wanted to make colleagues aware of that.
Thanks, Chris.
Should we like to go on to the insight report?
Just before you do, could I just so that if nobody wants to add anything else on the executive team report, I just wanted to sort of put on record the support and gratitude of the non-executive directors, including myself, for our executive colleagues. I mean, I think it's been an exceptionally difficult period. A huge amount of work has been done. Some of it's in relatively difficult and controversial areas, but I think the progress that everybody's made and the professionalism they've shown has been exemplary, and I just think we should take this opportunity to put that on record. And I'm pleased to see my non-executive colleagues all nodding and clapping and all the rest of it. So there we go. Good. Right, Chris, then that gives you a breather, but only a short one. Let's go on to the insight report. Thank you.
Okay, so there's a couple of topics in the insight report. Probably the most significant is the information we have on location level deaths. So CQC is today publishing our information on showing the death notifications involved in COVID-19 received from individual care homes between April last year and March this year. Obviously, the impact of the pandemic on people who use services and those that work in adult social care services has been devastating. And despite the best efforts of staff, COVID-19 has led to an increase in the number of deaths in nursing and residential homes alongside NHS and other services. Throughout the pandemic, CQC has asked care providers to be open with people in care, who are receiving their care and their loved ones about outbreaks. And CQC has worked with the Office of National Statistics to provide weekly information on how COVID is affecting care homes. The data itself covers residents involving COVID-19 under the care of a particular provider, regardless of where the virus was contracted or the death occurred. So there's a legal obligation on a provider to give us the information following a service user that might go in to use other services, contract COVID and die. The adult social care services must notify us of these deaths, and it must, even if the individual didn't contract COVID in the home and didn't die in the care home. It's important to note then that the death notifications themselves do not indicate poor quality care in an individual care home, particularly given what I've just said, and also other factors, including the rate of community transmission. In a particular organisation, we publish this information today alongside the Public Health England data on community transmission, and that appears to show the best link, if you like, between those two is between the community transmission in an area and care home deaths in an area. I just want to say it's very clear that professionals in all sectors have gone to extraordinary lengths to try to contain the effects of the virus, and our report, which we are publishing, is around prevention controls, shows that today. So we'll talk a bit more about the infection prevention control in hospitals in particular. So to say this doesn't represent a perspective on the quality of care. that an individual organisation has given. What you can, the way in which we do represent that is through our individual inspection reports and through our 8 ticks of assurance, and that information alone is a guide for the public on the quality of care and services. To support that, we've conducted over 5,500 inspections in residential and adult social care services since April last year. And those inspections and that information is what should be a good judge of the quality in individual care homes. So death notification shouldn't be used as a tool to understand quality. That's not what they're there to do. They are, and I think they will increasingly give us a view on how people move between different elements of the system and the effect that those moves might have. I just wanted to give maybe just a pause there and perhaps allow particularly Kate and perhaps the other chief inspectors to come in and offer a perspective as well.
Thank you, Chris. Thanks. So we're sharing this information today. This has been a long time in the coming. So we have thought long and hard and have given serious consideration about when is the right time to share this information. We are obviously, it's crucial that we are transparent with information that we hold. We've throughout this not wanted to do it at the height of the pandemic for fear that some of this information may be misunderstood when we share it. So just to restate, these deaths are not an indicator of quality of care within the service. Death notifications help inform my inspectors about when they might want to go out and do an inspection. So that sits alongside things such as whistleblowing, safeguarding, previous ratings, etc. And when we have information of concern, we go out, we visit a service, we write a report and we publish that on our website. And back in August, we developed our infection prevention control inspection. So a kind of focus inspection around how well providers were delivering good infection prevention control within care homes. And a large majority of providers were absolutely doing what they needed to across the 8 ticks of assurance. Lots of people have different views about us sharing this information today. Family groups, people who have sent FOIs to us over the last year have been really keen for us to release this data. We're also incredibly mindful of the impact that this may have on care homes and the sector, and we've been really tuned into that. So, for example, I was aware of a provider the other day who proudly talked about being COVID-free throughout the pandemic. And yet they will have a notification against their name because one of their residents had a stroke, went into a hospital, and during that period of time of them having left the care home, developed COVID and sadly died of COVID. So this is hugely sensitive. But if there's one message I can get across is that if you want to look at the quality of care delivered within a care home, refer to our inspection reports and our 8 ticks of assurance. Please heed the parallels of increase in prevalence in the community and likelihood or increased likelihood of COVID within a care home. That's the kind of predominant relationship that you will note when you look at the information. And care homes are parts of community, so you would expect that. And the majority of care homes that we've been out and seen, and actually in the last 12 months it's been 8,000 inspections that we've done. The majority of our care workers and our registered managers have been absolutely fantastic at doing a job that most people would find incredibly hard to do. So I really hope this lands with how we intend it. This is us being transparent, but also real clarity that many of these notifications against care homes are people who would have contracted and died from COVID having left the care home, but care home providers are legally required to inform us of it. Thanks, Peter.
Thank you, Kate. So, Chris, we're publishing this at 1 o'clock, is that right?
That's right. It's 1 o'clock today after the public board. We'll make it available to colleagues in the media as well. And we've also been engaging with public groups, people who represent people who use services and provider organisations. So they're all aware of our intention to publish today, and everybody will see the information at the same time.
And I can only support what you and Kate have been saying and hoping and urging people who choose to comment on this to take on board everything that you've both been saying and not to misrepresent the data.
Indeed.
We live in hopes.
Right. There were 2 other areas of the Insight report, yes, if I may, just to quickly touch on them. One of them relates also to infection prevention control in the NHS, and we've had a number of focused, well-led reviews that look at how NHS organisations have tackled the issues of good infection prevention control in their organisations. There is some really good practice. The key factors for how a service manages around leadership, culture and communications, having a plan, providing the right guidance, risk management and prioritisation, monitoring and record keeping, and learning and improving when things do go wrong. How fast does the information travel around the rest of the organisation? So there's some really good information which comes out from that, and the IPC, so the report is designed to give both information to providers to help them improve, as well as a wider understanding to stakeholders about how infection prevention control is being managed in hospital. And then the last area is about identifying and responding to closed cultures. And in this section, we just look at some of the highlights of learning so far about how risk can accumulate in some closed culture environments. There's a sample of 29 inspections of independent mental health and adult social care services where we found evidence of closed cultures and incidents of abuse and restrictive practices, issues of staff competence and training, a cover-up culture, lack of leadership, poor governance. Each one of these has been dealt with separately, as you might imagine, through our regulation. But again, we wanted to highlight this, partly because it helps both providers and indeed commissioners understand the challenges of closed cultures, and ensures that we can continue to apply pressure so that we see the reform, such as the reform that was announced today through the DHSC. And those are the three main areas of the Insight report. Happy to take any other questions.
Thanks, Ted.
Yes, thanks. Can I just comment about the infection control report? Thanks, Chris, and your team for putting it together. We inspected a range of hospitals where we had concerns, or we were just checking on the level of infection control. We contacted all hospitals and spoke to them through their processes. And I think the overarching picture of infection control hospitals is really positive. The staff have worked incredibly hard to maintain really high standards of infection control. And interestingly, we monitored nosocomial infections very closely, and the biggest predictor of nosocomial infections in hospitals is the community rate of COVID. And just as Kate was saying a moment ago that care homes are part of the communities they serve, so are hospitals and so are other services. And inevitably they are affected by the community prevalence of COVID. And I think in truth, the nosocomial infection rate was not a good predictor of the quality of infection control where we went in. We did find some infection control problems and took enforcement action, but it was generally feedback from staff or patients that drew our attention to poor practice rather than nosocomial infection, which, as I say, generally just reflected the overarching community levels of infection.
Thanks, Ted. Anything from anybody else? Chris, I think these Insight reports have been very insightful, if I may say so, and I think they've been valuable, and thanks to you and your team for putting them together over the last year or so. Robert.
I just wanted to voice my support for the publication of these figures, sobering no doubt they will be. I think it's really important that there is transparency about issues of this nature, so there can be open discussion about them. And there are, of course, challenges in communicating a proper understanding of what their significance is, but that will become apparent, I very much hope, through discussion, and it's much better to do that than not to publish these things.
Yeah, I agree absolutely with that, Robert. I think it does prompt good conversations about how we look at and manage the system response to deaths going forward. I just wanted to say, Peter, that this is I represent a cross-organisational group when we do these Insight reports. There's colleagues from right across the organisation, intelligence and digital, Rocco, and obviously the inspecting directorates that have contributed to make this possible. So this is very much a team effort from across CQC.
Thanks. Thank you. Well, thanks to everybody then. Seriously, they're very good. Can we move on then to provider collaboration reviews? Rosie, you've done two, and very interesting reading. Over to you, Rosie.
Thank you very much, Peter. So I'm really pleased today to be able to present these two reports, one looking at learning disabilities and one looking at cancer. Just to remind the board, provider collaboration reviews are something we started in the middle of last year, and the aim of them is to highlight good practice and pick that up the good practice that's happened during the pandemic, and also shine a spotlight on some of the things that we feel need to be improved across the systems. Just to Jura's point earlier, these are a great example of cross-directorate working across the CQC. Colleagues from all the directorates have been involved in this, and I think it as well as giving some really good insights into what's happening now, it does also help us to understand and develop our regulation of systems as we go forward. So learning disabilities and cancer are both areas which require the whole system to work together. And when I'm talking about the system, I'm talking about hospitals, community, people working in the community, mental health teams, primary care, adult social care, and very often the voluntary sector as well, and other parts of the system that really have an impact on people who use services. And in both of these areas, we have seen some really great innovation. We've seen examples of how people have worked together and gone above and beyond to deliver care despite the challenges. We've also found areas that we feel that need to be improved. And many of the areas we've highlighted in these reports are actually areas that predate the pandemic, but have been exposed or made more visible during the pandemic. I'm hoping that you'll notice, particularly with the Learning Disability Review, that actually we've very much tried to strengthen the voice of people using services in this report, which we think is really important. And actually, the Learning Disability Review has started with the people who use services, with the vignettes and the stories that we've heard as part of these reviews, and that's something I think we very much want to strengthen as we go forward and explore, and particularly with our strategic aim of regulating services through the eyes of people who use services. In terms of next steps, we will be using the information on this review and we will be sharing it widely, working with the engagement team, looking at how we can get these messages out to local systems, how we can share the learning, and working with Chris's team to look at the mechanisms for doing that. And we're thinking about blogs and podcasts and potentially meetings with CCGs and various other ways to share the learning that we get out of this, because I think it's really important that systems learn from what other places are doing, hear what's been working, and look at adoption as quickly as possible of those innovations that are making a significant difference. I want to just thank the systems that have worked with us on this. We've had very positive response from the systems that we've worked with each of these reviews, and thank you for taking the time to share the experiences and work with us on them. And I think before that, my only final thing just to mention for any of the public watching is you will see in the cancer report the concerns raised about early diagnosis and people still not always seeking help early when they experience symptoms because of the fear of COVID. What I would say to any of the public listening here is, please, if you have any worrying persistent symptoms, please go and get them checked out, because we want to make sure that you get the investigations and treatment that you need at an early stage. So that's all I was going to say, Peter, but very happy to take any more detailed questions about either of the reports.
Mark Saxton.
Sorry, Chairman, thank you. Rosie, thanks for super reports, really, really good. Can I say that I thought that the case studies in the learning disabilities were really powerful. And it showed that for James, Dominic, Sarah, Narinda, Dennis, Harry, Stephen, there were real stories of real issues that are of concern to us. We could see quite clearly from that report that communications and working together, what we call system working, there were a lot of challenges there. We saw the issue that we've talked about a lot before, this transition from child to adult services being a challenge, especially during the pandemic. And we saw technology being both an enabler, but also underlining inequality. So I thought that, that it was a really, really powerful report in that respect. The cancer report, equally powerful, but I think would be great to have stories as well, because they just personalize it and make it more understandable to the external audience. Can I just ask two questions? Or a question on each report. How are we going to use our voice? Because I don't get a sense of scale of the issue of deferred treatments from the cancer report. And I just wondered if you had a view about that, as how we can use our voice and extrapolate this data out nationally. And in terms of the learning disability report, I don't get a sense of scale of how the service and the support for people with learning disabilities is getting back on track post-COVID. So I wondered if you could just talk to that. But, overall, two really, really powerful reports, and thank you.
Thank you, Mark. And can I just take this moment to say thank you to Debbie Ivanova for her leadership on the learning disabilities report, because she was very much very keen to use those people's stories. And we are on very much a learning curve, and I think that's something we will continue to develop. And also Victoria Watkins for her leadership as well for the PCR programme. Overall. So in terms of cancer, we have been working closely with the Cancer Alliances at NHS England. I think we have, our intelligence team have done a huge amount to pull the intelligence that we have across the areas that we've looked at. I think at the moment, as you can tell from the report, we've only looked at a small number of systems. So we have presented the information that we've had in the context that actually this is in the systems that we've actually looked at. But we know that deferred treatment is an issue. We continue to work with NHS England and other partners to look at how we can raise the findings from this report, and we will continue to share the findings. We've already spent some time with the systems that we've been in to share those findings, work with them around the improvements that we feel need to be made in those areas, and ask for them for plans of action as a result. In terms of learning disabilities, again, and Kate may want to comment about this, and Ted may want to comment more about the cancer. Again, we have looked at only a kind of snapshot across the country, but to what I was saying earlier, with both reports, we will look at all of the information that we've got and continue to use that. This is not a snapshot, although it's a snapshot of what we've seen. The messages from these reports we will continue to use in our discussions, both nationally and locally. And we will be using a lot of this information in the state of care as well, which we're going to be discussing later today. So, so Kate, do you want to add anything? And Ted, do you want to add anything about LD and cancer?
Thanks, Rosie. Thanks. So board will remember 2 or 3 months ago, we established this new 12-month role for Debbie Ivanova, Deputy Chief Inspector, to provide some cross-organisational leadership around health and care services delivered to people with learning disabilities and autistic people. And Debbie has 3 priority areas of work, and one of those is around how people with learning disabilities and autism have access in a timely way to the right health services, and how they are supported in a joined up way as we go. This is all also our absolute direction of travel. So we know our collective ambition is to be able to track people's experiences, maybe during a crisis, or try and person with learning disability trying to get access to their annual health check or regular dental appointments, or maybe a stay in an acute hospital. We want to be able to track and describe people's experiences as they move through. And I think our provider collaboration reviews is a flavour of more and more what we will do as hopefully part of our kind of core regulatory business as well. And then you add into that are developing plans around being able to look at local authorities and the way that they commission services as well, and our emerging thinking around our role with integrated care systems. And soon we should have all the ingredients in place that we need to be able to say this is what it might feel like for an adult with learning disabilities in this part of the country to have access to well joined up health and social care within their area.
Thanks, Kate. Ted.
Yeah, thanks, Peter. Thanks, Rosie. So this cancer review is really helpful to us because it demonstrates a lot of really very good work that is going on in some of the areas we spoke to. And I think that's really very helpful as setting a benchmark. But I think the striking thing for me about it is if you look at the data, the impact that the pandemic has had on cancer diagnosis and timing of presentation. And there's no doubt that recovering from this, cancer services are going to face a tremendous burden to catch up with the ground that's been lost. And I think as we go forward inspecting cancer services and regulating them, we need to know how to support them and point them in the right direction. And this is a really good basis for that going forward. But I think we are going to have to develop our approach to cancer services, recognising the fact that they do have some catching up to do in terms that I described earlier on, in terms of the backlog of care.
Thanks. It's not something we've discussed, but I suppose there is something we need to think about, whether and when we repeat these exercises to see whether things have got better or worse. So we should at least think about whether we do PCRs, maybe with a slightly different methodology in a year or 2 years' time, to see how we're going. But no commitment now because we haven't discussed it. Mark Chambers.
Thank you, Peter. I mean, at the risk of repeating some of what Mark said, I did think, well, both of these reports are fantastic and really helpful. I did find the learning disability one and the addition of the experience information, it helped accessibility enormously. And it was very nicely presented as contextual. I think the danger of these things is if you put too much in, it becomes anecdotal. And I think you've got the balance absolutely right. And I think that report would be a useful model for going forward. And then the second thing I wanted to mention, and it's more a comment really, the section on health inequalities in relation to the learning disability report, it is terrifying and sobering. Average life expectancies of 23 years lower for those with the learning, for males with a learning disability, and 27 years younger for females with a learning disability, shows that there's a vast amount of required to be done at a system level in relation to tackling this. And it was not particularly encouraging, the amount of system work that's been done on that so far. So anything that we can do in relation to that going forward, I think would be really helpful.
Thanks, Mark.
Thank you, Mark. Could I just respond to that, Peter, if that's okay? Because I think by looking at things cross system, we are going to be able to have much more influence on what happens with inequalities. And I think the major theme we've got in our new strategy around inequalities and systems going hand in hand, actually, because I think we can start to look at really understanding how services are being designed and developed to meet their population needs and address those inequalities that we're seeing in all sorts of services at the moment.
I agree. Thanks, Rosie. Sally.
Yes, thank you, Peter, and others who've produced the reports. I echo what other board members have said about the value of these. I think there are very few organisations across health and social care who try to join things up in this way. And these type of reports are a really good example of those. I suppose I wanted to make a comment about the fact that these reports, while both being valuable, are actually quite different. So the learning disability and autism report is very much a big programme of work for CQC, something that we are taking forward, as Kate said, with Debbie over a year. So we have access to an awful lot of information, whereas cancer is a huge piece of work that we couldn't possibly get our arms around. And as you said, Rosie, we've looked at 7 or 8 different local areas, really. You can't get to everyone. So it's partly a question about where do we take these and how do we approach these in the future, and partly Peter's comment about whether we repeat them. So I'd suggest that we as a board perhaps have a further discussion about what topics should be in PCRs, what the kind of scope of them ought to be, what we think the biggest needs are across healthcare, which would help us deliver part of our strategy and improvement, and also when we should revisit. So I think really good piece of work. Some questions about the future and how expansive some of them are. Thank you.
Thanks,
Thank you, Sally. And could I just respond to that, Peter, if that's okay? Firstly, we specifically chose these topics during the population groups we've looked at during the PCR programme because of the concerns that we were hearing in the pandemic, and the fact that actually from our regional escalation groups, we were hearing concerns around all of the different areas that we've actually chosen for the PCRs. So that led to the topic development. We are using this as an opportunity to test new ways of presenting information and looking at information in light of our future role with potential future role around systems regulation. And I think that we've certainly learned a huge amount. We've had a variety of wash-up sessions after each PCR, and each PCR has learnt something to move on. And I'm hoping that you'll have noticed as we've presented them as they've gone forward, those improvements in how we've delivered this programme and how we've been presenting the information back to the board. In terms of going forward, those discussions, I would very much welcome a session with the board at some stage to look at the kind of the thoughts that we're developing around systems. I know we've discussed it on several times before. I think we need to think about how, when we look at systems, what levels we look at, whether we look at what we look at the system level, what we look at the pathway level, at the population group level. And I think those discussions we absolutely need to have with the board to look at where we go forward. And I think that will help us inform as well where we go back to in terms of what we look at in terms of the findings we've had now and what will be subsumed into our future regulatory role in systems.
Thanks. Let me bring Ian in probably to respond to that last point of yours, Rosie, and then Ted, I think you wanted to come in probably on the cancer report. Ian. Yes,
absolutely. I think it was to sort of to pick up that and Sally's point and your point from slightly earlier on, Peter. I think we've talked a couple of times during the course of this meeting in sort of unconnected ways, but on essentially the same point, which is we essentially do work at the moment at provider level. It's effectively a series of stovepipes. There's 40,000 stovepipes that we look at, and we capture the value in that work through a series of set piece reports. And increasingly over COVID, we've done different ways of doing that. Of course, the PCRs are about working right across a pathway, and of course we have done work in the past around a place. So sort of provider, pathway, place are the kind of ways of doing this. With the new methodology and the conversation we had earlier on around change, I think what we're really about there is to create a set of technology that does enable us to do the sorts of pieces of work where we can very quickly look across and say, in particular places with these characteristics, what are we seeing? In particular pathways, what are we seeing? That's almost like a pilot piece of work that then says, you know what, we actually need to go and do a deeper dive piece of work to look at these particular facets of a particular pathway or place in more detail. And I think that sort of idea of systematizing what we do to take the value out of out of what essentially are PDF reports at the moment, and making that value accessible both horizontally and vertically is really quite exciting, I think, and it gives us an opportunity to comment in ways that we just frankly never thought possible, much faster about a broader range of topics than we could ever have thought of. So hopefully, as we bring back versions of new methodologies and so forth in coming months, you'll be able to start to see the opportunity to answer the questions that that you asked, Peter and Sally. Thank you.
Thank you. Let me bring Chris in, and then we'll give the final word to Ted. Chris, you're on mute, Chris.
It had to happen once, didn't it? Sorry, just to build on what Ian was saying and also what Sally said, I think it's really important that we can use these both nationally and also regionally. So as we begin to get more into a regional perspective on how ICSs and regional areas are performing, we can use some of that information in that way. We're also looking at our strategy and where we want to have a voice or work with others to develop a voice. So I have a regular conversation with about 30 organisations that have other data that we work regularly with, and public groups. And I think what we're trying to do is develop a sort of a topics of interest that we want to explore over the coming 12 months and use that as a guide for where we might want to have thematic presentations of data, or develop a perspective on a particular theme, as we have done with learning disabilities. I think there'll be other versions of that we want to develop, but I think we should plan for it and plan the resources around it to do it well.
Thanks, Chris. Ted.
Yeah, thanks, Peter. Cancer services are par excellence. The kind of service that looking at it on a provider by provider basis doesn't work, because cancer care is provided as a pathway by multiple providers working together. And so before the pandemic, we were looking at developing a thematic approach to cancer services. So we could look at it, if you like, through the experience of patients receiving those cares rather than through the provider's eyes, which is where we've effectively been doing it before. The pandemic, to some extent, has brought that to the fore, because, as I said, the pandemic has exacerbated problems we're already aware of. And I think the effect on the cancer services, as this PCR report demonstrates, are quite profound. So there's lots of good care going on, but actually, how does that add up to an integrated care pathway for patients? And I think that's the question we need to ask. So I think this PCR is really useful as a starting point, but we need to develop, if you like, a much more system-focused approach to cancer services going forward. And I think that is a priority coming out of the pandemic.
Thanks, Ted. I think that's a good point to leave this subject on, but thanks to everybody, Rosie, who's been involved in producing these reports, because I do think they have been excellent. So I think that then takes us on, Sally, to the annual report from the Audit Committee, please.
Yes, thanks, Peter. So this is the 10th annual report of the Audit and Corporate Governance Committee, commonly known as ACGC, one of the board's key committees. I've only been there for less than a year, and we have some new members. So our thanks go to the people who staffed the committee before we joined earlier this year in January. As members of the public will know, the job of ACGC is to provide assurance to the board and to Ian, the Chief Executive, as our accounting officer, that our risk control and systems of governance are reliable and that they have integrity. So it's an assurance role that we fulfill. There is a report in the papers, but I'm just going to pick out some highlights if that's okay. We obviously have our own internal systems of control, risk management and governance, but we also enlist the support of internal auditors who report on different parts of our organisation or the ways in which we do things and provide their opinions and recommendations. And we're also externally audited by the National Audit Office, who work on our annual accounts and allow Ian to sign those off and then sign them off themselves before we lay in Parliament. I think the key message is that given all of the challenges of the pandemic, we feel that we're in a good place and that our systems of control and governance are reliable and do have integrity. So that's the positive message you should take. I think there have been two challenges over last year, clearly the pandemic, but also a significant change programme that we are undertaking within CQC. So we have established a subcommittee of the Audit Committee, which is looking more closely at some of those business cases and the transformation programme that we have, just to be able to provide an extra level of assurance. And our internal and external auditors have also had a view on that change programme. So the work that Audit has overseen in conjunction with our partners, we've overseen the arrangements for risk, and I should pay tribute to the Regulatory Governance Committee, one of our other key committees, which specifically looks at CQC, because we are a regulator, at the risks relating to regulation. So thanks to them for all their work. We've done a combination of work on business as usual, including our own internal management assurance by directorate. We've also looked at transformation projects, including in digital, as we are putting together a new operating model with our people plan, and also the way that CQC regulates and has had to adapt over the last 12 to 18 months as the pandemic has happened. And we've also done some work around improvement, naturally. We're not just about assurance for what's happening now, we are about improvement into the future. So I wanted to say thank you to Chris Usher and the team, but also everybody who's contributed to the work of ACGC. It is right across the organisation, and thanks to all those executive board members and their teams who've come to present to meetings. We've worked well with our internal auditors. I'd like to say thank you to them. There'll be more detail on their opinion in our annual report and accounts when it's published in the autumn and laid before Parliament. But we have committed to delivering and working with them on all their recommendations for improvement in particular areas of our business. And our external auditors, the National Audit Office, are also currently working on our year-end accounts. And again, their opinion will be in the annual report and accounts in the autumn. So I suppose I'm happy to take questions, but just wanted to reiterate the positive message at the start, that the assurance that our systems are reliable and comprehensive is there, and that it meets the needs of the board and the accounting officer. And the recommendation is that you note the report. Thank you.
Thank you, Sally, and thanks actually to you personally, because you sort of got parachuted into this without much of a organised handover and everything else, and have done a great job over the last few months. So thank you very much indeed. Any questions or comments on the ACGC report? In which case we will note it as requested. But thanks again, Sally, and thanks to everybody on the committee. Is there any other business the board wants to raise this morning? In which case that's the end of the formal part of the meeting. We do have two questions from a member of the public, Robin Pike. The first question is, how does CQC liaise with the Parliamentary and Health Ombudsman, and how does it respond to its decisions? Probably a number of us could answer that question, but Chris, why don't I give it to you?
Okay, so Ian meets regularly with the Chief Executive Officer and the Deputy Ombudsman, usually once a quarter, or at least 2 or 3 times a year. Colleagues also meet more regularly with the PHSO and others at a working level to consult on particular issues that affect their work and ours. So we probably hold those meetings at least every 4 to 6 weeks. In terms of our work, where there is an issue where they are investigating a complaint against CQC, they'll regularly have a conversation with the National Complaints Team and ask for information, and the Complaints Team will help sort of share that information and shape what we offer back to the PHSO when they're conducting an investigation. Following this, the PHSO will make their decision and issue a report to all the parties that are concerned, and if there's any recommendations for us, they'll usually talk to us well in advance of those so we can understand them and help shape any responses that we need to make.
Great, thank you, Chris. And then the second question is, how often are whistleblowers working in hospitals for patients with learning disabilities reporting concerns Ted, can you answer that one?
Yes, well, thank you, Robin, for the question. In directly answering your question, over the last 3 years, we've had 965 whistleblowing concerns raised about sites where we know that patients with learning disabilities are being looked after. That's about 20% of our total whistleblowing for hospitals. I've said to the board report before how important staff raising concerns about the services they provide is. So can I again express my thanks to all staff who've raised concerns for us. It is a very important part of us understanding the risks in the system. And during the pandemic, that has been particularly true, as I'm sure we've discussed before. The number of whistleblowing concerns raised with us has risen over the last year, and that is something that has really helped us maintain a risk-based focus on services. So we very much welcome staff raising concerns with us. We want to develop a culture in which staff, of course, can raise concerns locally and have them taken seriously. But when they can't do that, we are keen to hear their views.
Agreed. Thank you, Ted. And there are no other questions from the public, so there is no other business. So that is the end of our public board meeting. Thank you very much indeed. And miraculously, everybody, we